Place the patient's hand over the abdomen, elbow adducted and the humerus internally rotated. Place your palm on the patient's shoulder anteriorly. The area that feels like a ball under your palm is the general target area. You should be able to feel this ball even on obese patients by pushing deeply. Place the ulnar aspect of one hand vertically over the axilla. Place the ulnar aspect of the opposite hand along the midline of the upper arm laterally. Place your thumbs together over the arm. This identifies the vertical line of the insertion on the proximal humerus. Palpate deeply as you climb up the humerus to the surgical neck. It will feel like a golf ball on a tee. The spot where the ball meets the tee is the surgical neck. The insertion site is on the most prominent aspect of the greater tubercle, 1 to 2 centimeters above the surgical neck. Prepare the site by using antiseptic solution of your choice. Use a clean, no-touch technique, maintaining asepsis. Remove the needle cap. Point the needle set tip at a 45-degree angle to the anterior plane and posterior medial. Push the needle tip through the skin until the tip rests against the bone. The 5 millimeter mark must be visible above the skin for confirmation of adequate needle length. Drill gently into the humerus 2 centimeters or until the hub reaches the skin in an adult. The hub of the needle set should be perpendicular to the skin. Hold the hub in place and pull the driver straight off. Continue to hold the hub while twisting the stylet off the hub with counterclockwise rotations. The needle should feel firmly seated in the bone, which is the first confirmation of placement. Place the stylet in a sharps container. Place the easy stabilizer dressing over the hub. Attach a primed Easy Connect extension set to the hub, firmly securing by twisting clockwise. Pull the tabs off the Easy Stabilizer dressing to expose the adhesive and apply to the skin. Aspirate for blood or bone marrow, which is the second confirmation of placement. Inability to withdraw or aspirate blood from the catheter hub does not mean the insertion was unsuccessful. Consider attempting to aspirate after the flush. Secure the arm in place across the abdomen. If unable to place the patient's hand over the abdomen, or if the arm must stay restrained at the patient's side, with the arm elbow against the body, adducted, rotate the hand medially until the palm faces outwards, thumb pointing down. Then palpate for the insertion site in the usual manner.
We've reflected out the subclavian vein, which is this flat atonic vessel. We have a properly inserted humeral IO connected to saline. We're going to infuse the saline, and you can see real-time engorgement of the subclavian vein. To help better understand the humeral anatomy when we place a humeral IO, in this adult patient, generally 40 kilograms and up, we've reflected back the soft tissue, which you can see will vary from patient to patient. We also have the lateral deltoid. When we marry those two together, you can see how the 45 millimeter needle is essential to go through both layers and through the cortex of the bone. As you can see, this patient is in the supinated palm up position. When the palm is up in the patient, it exposes the bicep brachii tendon. The optimal method is to take the palm and place it over the abdomen. As it does that, it immediately rotates the bicep brachii tendon, leaving a very large area of cortex to penetrate. Again, when we have the palm supinated or up, the tendon is exposed and strikeable. When the palm is placed over the abdomen, it's medially rotated. If you're unable to place the palm in this position due to patient variances, the alternate method is to take the palm and put the thumb rotated inward and down. It again medially rotates the bicep brachii tendon, yielding the optimal insertion spot. You can see the surgical neck is where the shaft marries that humeral head, yielding the greater tubercle, which is the ideal location for insertion.